Dr. Donald Abrams is a professor emeritus of medicine at the University of California, San Francisco. He has an integrative oncology consultation practice at the UCSF Osher Center for Integrative Medicine. He has long been interested in clinical trials of complementary and alternative medicine interventions for HIV, AIDS, and cancer, including evaluations on medical cannabis. He completed placebo-controlled study of smoked cannabis in patients with painfully HIV-related peripheral neuropathy, as well as a study evaluating vaporization as a smokeless delivery system for medical cannabis. He conducted an NIDA-funded trial investigating the pharmacokinetic interaction between vaporized cannabis and opioid analgesics in patients with chronic pain. Please welcome Dr. Donald Abrams.
A British surgeon working in the British East Indies Company who saw all the benefits of cannabis, and eventually it reportedly later became Queen Victoria's favorite treatment for her menstrual cramps, that being W.B. O'Shaughnessy pictured and not Queen Victoria. The proponents of cannabis at that time felt that it was an analgesic, sedative, had anti-inflammatory and anti-spasmodic and anticonvulsant properties. Cannabis was available as a medicine in the U.S. in the early part of the last century, and as you can see, produced by many of the precursors of what we consider big pharma today. Cannabis as not a medicine actually, again, dates back to the early 1900s, when the interest in its multi-potential uses decreased a bit with the availability of agents that were more targeted, if you will, for the specific symptoms and conditions that cannabis was felt to treat. In 1937, Harry Anslinger, pictured here, a prohibitionist and the first head of the Federal Narcotics Bureau, introduced the so-called Marijuana Tax Act, using the Mexican name, which did sort of an end run around physicians who knew the substance as cannabis. He introduced in Congress this act, which imposed $1 an ounce for medical use and $100 for recreational users, which in 1937 dollars was a significant tax. In 1942, cannabis was removed from the U.S. pharmacopoeia. In 1961, the United Nations Single Convention Treaty classified cannabis as a dangerous narcotic, and it is neither dangerous nor a narcotic. In 1970, the U.S. Controlled Substances Act placed cannabis in Schedule 1, which means high potential for abuse and no accepted medical use. And here's the company that cannabis keeps in Schedule 1. By the way, I tend to call it cannabis as opposed to marijuana, probably in defiance of Harry Anslinger. Harry was felt to be a racist and thought that widespread use of cannabis by African-American jazz musicians and Mexican migrant laborers was going to lead to increased crime and mental illness in the United States. Hence, when he introduced the act, he used marijuana. And so some of us prefer to use cannabis to be more scientifically precise. We know that the plant is a complex botanical. It contains cannabinoids, which are 21 carbon terpenophenolic compounds that have medicinal activity. In addition to the cannabinoids, the plant contains terpenes, which give each strain its characteristic smell, and flavonoids. And both terpenes and flavonoids in medicine, botanical medicine, have a biologic activity. The highest concentration of the bioactive compounds are found in dried flowers of the female plant of Cannabis sativa or Cannabis indica. The most well-known cannabinoids are delta-9 tetrahydrocannabinol, or THC, which is mainly responsible for the psychoactive component of the plant. Delta-8 THC was studied a long time ago as an antiemetic in children with cancer receiving chemotherapy in Israel, and felt to be equally potent to delta-9 THC in relieving nausea. CBD, or cannabidiol, has catapulted really to the top of the most favored cannabinoid list because it is considered to be not psychoactive. Again, there are at least 100 other cannabinoids that are identified in the combustion products of the plant. Personally, I think focusing on the individual cannabinoids as opposed to the whole plant which provides a so-called entourage effect, is a little short-sighted. Some of the non-THC cannabinoids, as I mentioned, are CBD. Cannabinol, or CBN, is a degradation product of delta-9 THC and is felt to be useful for sleep. Cannabichromene, cannabigerol, also becoming popular. Delta-8 THC, which has a little psychoactivity, is presenting problems to regulators because it is not delta-9 THC, so it is not regulated very closely. Tetrahydrocannabivirine, I think, is a very interesting substance because it decreases appetite for food, for tobacco, and perhaps for opiates. So I think we'll hear more about that in the future if we're going to continue to look at isolated cannabinoids. The non-THC components of cannabis, again, are probably present in the plant to enhance the beneficial effects of THC and also reduce some of the adverse effects. So it's felt that a THC with CBD reduces some of the anxiety that THC may produce in some patients. And again, the terpenoids and flavonoids themselves may actually increase cerebral blood flow. And Raphael Mechoulam, the father of cannabinoid chemistry in Jerusalem, said that anybody undergoing an acute stroke should receive cannabis to decrease the extent of brain damage. And actually, the National Football League has adopted this and has now made it okay for players to be found to have cannabis in their blood because they're using it to prevent brain damage. So we have in our body cannabinoid receptors, so-called CB1 and CB2. The CB1 receptor is one of the most densely populated receptor in the human brain. When I ask audiences of physicians on Zoom, how many of them learned about the CB1 receptor in medical school, the responses from two audiences of 50 and 70 providers was 5% and 10%. And that shows you the extent of reefer madness, that we're not teaching medical students about the most densely populated receptor in the human brain. The CB1 receptor is found throughout the body, as is the CB2 receptor, which was initially isolated in immune cells of the spleen and the peripheral blood. So why do we and all animal species down through sea squirts have these cannabinoid receptors? You've never seen a monkey or a dog or even a sea squirt smoke a cannabis cigarette. Well, similar to our own endogenous opiates, we make our own endogenous cannabinoids, so-called endocannabinoids. And again, the first was isolated by my friend and colleague Raphael Mechoulam, 91 years old today, in Jerusalem. And he named it anandamide after the Sanskrit word for bliss. The second most identified or characterized cannabinoid is 2-arachidonoglycerol, or 2-AG. So why do we and all animal species have this system of cannabinoid receptors and endogenous cannabinoids? The endogenous cannabinoids are made on demand, synthesized from membrane lipids, and when their work is done, they are broken down each by a different enzyme. And it's felt that when the endocannabinoids complex with the CB1 receptor, they lead to changes in the signal in the cell that are altering appetite, immune function, pain, intraocular pressure, cognition, emesis, etc. And when the endocannabinoids complex with the cannabinoid 2 receptor, they're impacting changes in immune function, cell proliferation, inflammation, and again, pain. And we now believe that the endocannabinoids also complex with something called the vanilloid receptor. And as you can see, pain is also listed there. So our endogenous cannabinoid system of the cannabinoid receptors and the endocannabinoids may have in fact developed to help us modulate our response to painful stimuli. I was one of the 16 members of the National Academies of Science, Engineering, and Medicine Committee, which reviewed 10,000 abstracts and articles in the medical literature and published the health effects of cannabis and cannabinoids in January of 2017. And in our findings, we concluded in the single chapter on therapeutics that in adults with chemotherapy-induced nausea and vomiting, oral cannabinoids are effective antiemetics. And in adults with chronic pain, not surprisingly, patients who were treated with cannabis or cannabinoids are more likely to experience a clinically significant reduction in pain symptoms. I mentioned in the single chapter on therapeutics, I think it's important to note that the only legal source of cannabis for research up until very recently has been NIDA, the National Institute on Drug Abuse. And NIDA has a congressional mandate that they can only study substances of abuse as substances of abuse. So if you want to study the potential therapeutic benefit of cannabis, you must use NIDA product, but they cannot fund such a study. So you need to find funding elsewhere. On the other hand, they spend $150 million a year funding studies looking at the adverse effects of cannabis. Hence, in this 500-page volume, we had one chapter on potential health benefits and 13 on potential harms. Next slide. So what do we know about cannabis and chemotherapy-induced nausea and vomiting? Well, I think it probably in the 70s, a time when Jimmy Carter was president, prior to the Reagans and their intense Just Say No campaign, young people with young people cancers, Hodgkin's disease and testicular cancer, found that smoking cannabis produced greater relief from nausea and vomiting than the only available agent at the time, prochlorperazine. And this prompted a small pharmaceutical company in conjunction with the National Cancer Institute to evaluate delta-9 THC as a potential antiemetic. And in clinical trials, randomized placebo-controlled trials, oral THC was better than placebo and felt to be equivalent or even superior to prochlorperazine. Patients told us that they preferred smoking to taking it orally, but ultimately dronabinol was approved in 1986 for the treatment of chemotherapy-induced nausea and vomiting, and the indication was expanded to include AIDS anorexia in 1992. But if you can read the advertisement that's pictured there, it said that dronabinol was approved for the treatment of anorexia or loss of appetite associated with AIDS weight loss and not for weight loss itself. And that's because in the clinical trials, although dronabinol increased appetite, it did not lead to an increase in weight. So why would the FDA expand the indication? Well, up until 1992, our federal government, in all of its wisdom, despite saying cannabis has no accepted medical use, was providing a handful of patients with 300 cannabis cigarettes monthly, patients with so-called orphan diseases. And they were afraid that patients with AIDS wasting, numbering in the thousands, if not tens of thousands, would come knocking on the door saying, "We have an orphan disease. Please send us 300 cannabis cigarettes each month as well." So in 1992, Bush 1 closed the compassionate use program, and the FDA expanded the indication so the government could now say, "See, you don't need our marijuana. Here's marijuana." And dronabinol is, in fact, really not the same as cannabis. So are there any clinical trials of cannabis and chemotherapy-induced nausea and vomiting? And again, because of the restrictions that I've already outlined, there are only 3 controlled trials in the medical literature. And in 2, cannabis became available only after dronabinol, its main component, had failed, so not likely to be effective. The 3rd study, in my mind, is pretty much uninterpretable. Nabiximols is a whole plant extract of cannabis modulated to have a 1-to-1 ratio of THC to CBD, licensed and approved around the world for treatment of spasticity associated with multiple sclerosis, but not approved in the United States at this time because no clinical trials here have demonstrated any significant benefit. In a placebo-controlled crossover trial in 16 patients with cancer receiving chemotherapy, 5 sprays a day of nabiximols was more effective than placebo. Certainly a small study, but hints that it may be useful. Another study in non-cancer patients looked at 153 outpatients coming to gastroenterology clinics for evaluation, and they rated 29 antiemetics. And of those, cannabis scored higher than ondansetron, which is the most widely used antiemetic in our armamentarium today. So that, I think, is interesting. This is an email from a patient in the days when I needed to sign letters so patients could access medical cannabis until California went to adult use in 2018. Patient is a 48-year-old gentleman with metastatic colon cancer contacting me to get an extension of the medical marijuana letter that I previously issued. He says, although I did not use it until my last 5 sessions of chemo, me getting over the stigma of its use, it did what no other drug could do, completely solve the severe nausea I had. It allowed me to play with my children, attend their sports and school functions, and just function very normally in day-to-day activities. I cannot thank you enough for giving me that option. I'm currently on a chemo vacation after a clean scan, and the only time I use medical marijuana now is when I have trouble sleeping. I would like to continue to use it for that purpose instead of relying on pharmaceutical options. And I believe it was Melissa Etheridge who came out and said that the only way she was able to tolerate adjuvant chemotherapy for her breast cancer was through the use of medical marijuana. Unfortunately, the American Society of Clinical Oncology Guidelines Committee convened an expert panel, and they recommended that the FDA-approved cannabinoids, dronabinol or nabilone, only be used to treat nausea and vomiting that's resistant to standard antiemetic therapies, even though it was found to be as effective as, and the evidence remains insufficient to recommend marijuana in this setting. The data in states where cannabis has been approved demonstrates that fewer pills are prescribed for patients to treat pain when cannabis is available for medical use. So the prime uses of cannabis are for chemotherapy-induced nausea and vomiting, stimulation of appetite, and for pain, including neuropathy, because cannabis is certainly less addictive and has fewer side effects than the opiates. It also has some use for insomnia, depression, and anxiety. And you can see then that cannabis is useful in our armamentarium of treating symptoms in patients with cancer. The question then comes up, does cannabis itself cure cancer? And this article published by a group at Stanford found that online search volume for cannabis and cancer increased 10 times the rate for standard cancer therapies. And the top false news story about cannabis curing cancer generated millions of engagements on social media compared to the accurate story that debunked it, which was less frequently visited. So where does it even come from that cannabis may have anti-cancer activity? In 1975, investigators from Virginia Commonwealth University reported that delta-9 THC, delta-8 THC, and cannabinol inhibited Lewis lung adenocarcinoma cell growth in the test tube and in mice. Interestingly, CBD did not, and if anything, caused increased size of the tumors. Since that time, there's been an increasing body of preclinical evidence, that is, in the test tube in animals, suggesting that cannabinoids may have some anti-cancer activity. And we know the plant is an antioxidant and has anti-inflammatory effects as well. And these are things that I look for in advising my integrative oncology patients to seek. So there's the possibility of anti-tumor activity by direct impact of cannabinoids with the cannabinoid receptors, inducing cancer cells to commit suicide. Multiple cell lines are inhibited in the test tube. And if you take tumors from humans and transplant them into nude mice who don't have an immune system, so they don't reject these tumors, these are the tumors that respond to cannabinoid interventions: lung, breast, colorectal, and pancreas carcinomas, skin cancers, including melanoma, lymphoma, and most well studied are brain tumors. So Manuel Guzman, a friend and colleague from Madrid, has a laboratory that studies the effects of cannabinoids on metabolism. And the most metabolically active cells in the body are the brain cells. So his lab would grow up rat brain in culture and add cannabinoids and see what happens. And they said, maybe we could do our work faster if we grew up a rat brain tumor. So they grew up a rat brain tumor, added cannabinoids, and everything died. And they said, "Ooh, we must have done something wrong." So they did it again, and everything died. They said, maybe this is a bad batch of cannabinoids. So they went back to the healthy rat brain and they added the cannabinoids, and everything lived. So since that time, they've identified many different ways in which cannabinoids impact brain tumors. First of all, as I mentioned, when they interact with the CB1 and CB2 receptor, which are overexpressed on these brain tumor cells, they cause the brain tumor cells to undergo apoptosis or to commit suicide. In addition, cannabinoids inhibit vascular endothelial growth factor, or VEGF. This is the same pathway that's inhibited by bevacizumab, a very expensive pharmaceutical that's available. It stops new blood vessel formation, and new blood vessels are what allow the cancer to grow bigger by supplying more blood. In addition, they've demonstrated that cannabinoids block the activity of an enzyme called matrix metalloproteinase 2. Matrix metalloproteinase 2 allows cancer cells to become invasive and metastasize. So, with all that evidence, it's pretty impressive. However, we in the National Academies of Science, Engineering, and Medicine concluded that there was no or insufficient evidence that cannabis has any activity against cancers. And what we did find, the charge that the committee had was to look at meta-analyses and systematic reviews of human clinical trials. And if such reviews were not available, then we should look at well-conducted, randomized controlled clinical trials. Well, in the literature, there was only one meta-analysis, and it was of 34 in vitro or in animal model experimental studies. And there was only one pilot human trial that was included. Again, all but one of the studies in vitro showed that cannabinoids selectively do kill tumor cells. And again, in addition to the direct anti-tumor activity, there's the anti-blood vessel formation and the anti-metastasis effects. However, since there was nothing in humans, we could not support that cannabis has any activity against tumors. Now, Manuel Guzman, a PhD, went to the Canary Islands and found 9 patients with recurrent brain tumors, glioblastomas, and he dripped THC by way of a catheter into their tumors. And he concluded there was no effect difference from the chemotherapy itself. And that was the first human clinical trial of a cannabis-based medicine for treatment of cancer. A recent study published this year by a group in the United Kingdom and Europe looked again at patients who had recurrent glioblastoma multiforme, the most aggressive brain tumor known. And this was an early phase study that looked at a very small number of patients, 12 patients with recurrent glioblastoma receiving standard salvage chemotherapy, used nabiximols sprays under the tongue of that 1-to-1 ratio of the whole plant extract, modified to have a THC to CBD ratio of 1-to-1. 9 patients used placebo. At the end of the day, 2/3 of both groups progressed by 6 months. So their brain tumors recurred or advanced. However, 1-year survival was quite different between the two groups. 83% in the group that was using the nabiximols compared to 44% to the group using placebo. That was statistically significant, although the authors tell us that the study was not powered for survival. That is, it wasn't big enough to really make a conclusive statement about a survival endpoint. Interestingly, the overall survival at 2 years still favored the group receiving nabiximols, 50% versus 22%. So this again is another suggestion that there may be some benefit, particularly in patients with brain tumors, but as yet it is not, the data that we have is not sufficient to really say that clearly. For people that say, I cured my cancer with cannabis alone, my friend and colleague Dylan Zilla, working in Minneapolis, has started what he calls the CATA study, Cannabis as an Anti-Tumor Agent. And he is inviting patients who believe that their cancer was cured just by cannabis without use of conventional chemotherapy, radiation, hormonal, or immunotherapies, to go to the website www.catasurvey, C-A-T-A survey.com, and participate in this very important clinical trial. Because certainly in my practice as an integrative oncologist, I see patients who have waited months to come see me for an appointment. And during that time, they're treating a potentially curable malignancy with highly concentrated oils of THC, CBD, or some combination of the two. And now their disease is metastatic and they're uncurable. And for me, that is very painful because there is no evidence that these treatments are curing cancer. So a very common question that I get from patients is, what should I take? What is the right ratio of THC to CBD? Should I use CBG? What about CBN? You know, as an oncologist, I have no idea what is available in the dispensaries that my patients go to. So to answer that question, I really have very little or limited data to help me. Next slide, please. One question always is, should I just use CBD if I don't want to get high? Well, here's a question, or here's a study that answers that a little bit. This is from the Netherlands, where they sell different cannabis strains in the pharmacies. They have two high THC, low CBD strains, and one strain that's balanced or slightly in favor of CBD. And when they ask patients which works best for appetite, the low THC, higher CBD strain was less effective than the higher THC strains. And this was supported somewhat by participants using the Relief app. This is an app that you can get on your device where you can provide information on your experience using cannabis. 3,341 people answered questions about improvement of symptoms on a 0 to 10-point scale across 27 different measured symptoms. They reported that their average symptom improvement was 3.5 points. Dried flower was the most commonly used product and was associated with greater symptom relief. Only higher THC levels were associated with greater symptom relief and the prevalence of positive and negative side effects. CBD potency was generally not associated with significant symptom change or side effects. So personally, I believe THC is the medicine and CBD is there to modulate the effects of the THC. So one of the companies that sort of specializes in selling CBD products put out this little discussion of what the different ratios of CBD to THC mean and how they affect different patients. Certainly the balanced 1-to-1 is going to be more psychoactive than something that is highly CBD dominant at a dose of a ratio of 18-to-1. Again, this is probably the most common question that I'm asked by patients. What is the right ratio? The only ratios that have been studied in the medical literature are nabiximols, which is a 1-to-1 ratio of CBD to THC. More frequently, we're seeing other ratios being reported on in the medical literature, but to date, we really have no information to discuss the efficacy of CBD and THC in different ratios. And now CBG and other cannabinoids are arising to be more interesting, in fact, than CBD. As I mentioned, you can now get CBN or cannabinol as something that may be useful for sleep. Personally, I've tried it and I found that I was a little groggy in the morning and did not enjoy that. Patients also ask, how should I use cannabis? I see a number of older patients, particularly women in their 60s and 70s, who don't want to smoke a medicine. So they go to the dispensary and they're told only eat a quarter of the cookie. So they eat a quarter of the cookie and nothing happens. They eat another quarter and nothing happens. And then they eat the whole cookie. And then they call me 3 days later, perhaps after a visit to the emergency room, with a dysphoric reaction saying they're never going to do that again. I tell patients, if you want better control over the onset, the depth, and the duration of the effect, inhalation is probably better than oral ingestion. When you inhale cannabis, the peak concentration of THC is reached in 2.5 minutes, and it dissipates quite rapidly over the next 30 minutes. When you take an edible or any other oral product, it takes 2.5 hours to reach a much lower peak. However, when the delta 9 THC goes through the liver in the so-called first pass metabolism when taken by mouth, it gets converted into an even more psychoactive 11-hydroxy product. So that's why taking by mouth, you get a more delayed effect and you can get more zonked. And as an oncologist, I am anti-sugar. Gummies and edibles are all sugar. So I advise my patients, please don't do gummies and edibles. And if you are inhaling, smoking is probably better than vaping an oil, or vaporizing flower is something that I like also more than vaping an oil. I always say I am an oncologist, so I am a little bit conservative. I know the long-term effects of inhaling a flower. I don't know the long-term effects of inhaling an oil, and it turns out that they're probably not so good for you. Now we have under-the-tongue products, oils, tinctures, even chewing gums. And when you put something in your mouth like that, you immediately absorb some from under your tongue, and then you swallow the rest. So you have sort of a hybrid between inhalation and oral ingestion. So I find most of my patients now are using cannabis as tinctures or oils. Many patients do make their own suppositories out of coconut oil, and they claim that they are certainly effective. Mahmoud El-Souleh, who grows cannabis for the government in Mississippi, claims that you cannot really absorb THC rectally, but my patients say, yes, they do. So the mode of delivery for better control, as I said, over the onset, the depth, and the duration of the effect, inhalation may be optimal, achieving a higher peak concentration, but a shorter duration effect than oral ingestion. And again, oral ingestion leads to a greater effect because of the formation of the 11-hydroxy metabolite. Tinctures and oils provide hybrid kinetics. So then patients want to know what dose. And the answer is, I don't know. First of all, I don't know what products are out there. The recommendation that we use is start low and go slow. Even though that's grammatically incorrect, it should be start low and go slowly. I have the advantage of working with a group called Med1Rx, and they are pharmacists that graduated from UCSF, and they consult with patients online, and they help them after finding out what it is they're trying to treat and what other medications they're on. They will recommend an optimal tincture product to the patients. Side effects of cannabis are important to note: dizziness, dry mouth and drowsiness, euphoria, changes in blood pressure, reddening of the eyes, relaxation of the muscles. Less commonly, we see anxiety or depression, increased heart rate, impaired memory and learning, and motor coordination difficulties. Cannabis-induced euphoria is often described as a side effect of treatment. It may be a side effect, but I don't consider euphoria to be an adverse experience, particularly in a terminal patient, and is a single treatment that increases appetite, decreases nausea and vomiting, relieves pain, and improves sleep and mood. Certainly a potentially useful tool in oncology and palliative medicine. I ask all of my patients, what brings you joy? And the number of patients who tell me that gardening brings them joy is not insignificant. I feel if you feel that part of you has died or you are dying, the ability to bring life out of the ground is a blessing. And if you can grow your own medicine, that's very empowering. So, what about safety? Again, I caution older people and people with cardiovascular disease that cannabis can raise the heart rate and it can also raise and lower the blood pressure. So people with cardiovascular disease should be careful. Cannabis can also cause postural hypotension, so you get dizzy when you stand up and may fall down. Older people, I'd hate to have somebody break a hip. One of the things I'm concerned about is that by the actions on the pathways in the liver that metabolize prescription drugs, both high concentrations of THC and CBD may alter blood level of prescription drugs, perhaps making them more toxic. So I caution patients taking prescription drugs to be careful using oils with highly concentrated THC and especially CBD. Inhaling any plant material can increase the risk of chronic bronchitis. Those with a history of an adverse experience to cannabis should avoid it or use it carefully. And then there's this new syndrome or newly recognized cannabis hyperemesis syndrome, where paradoxically, instead of getting relief of nausea and vomiting, patients actually get nausea and vomiting that appears to be uncontrollable. No deaths have ever been reported from an overdose of cannabis. In contrast, one would need to smoke 800 cannabis cigarettes to kill you, and that would be death from carbon monoxide and not from cannabinoid poisoning. By comparison, alcohol and nicotine are much more lethal. And unlike opiate receptors, which are dominant in the brainstem, which control breathing, there are very few cannabinoid receptors found on the brainstem. The addictive potential and minor withdrawal syndrome are less than or equal to those of caffeine. Well, what about smoking? Doesn't smoking increase the risk of cancer? Smoking tobacco certainly is still responsible for a high rate of cancer. The National Academies of Sciences concluded that there is moderate evidence of no statistical association between cannabis smoking and the incidence of lung cancer, and moderate evidence of no statistical association between cannabis use and the incidence of head and neck cancer, both of which are increased in tobacco smokers. And this was supported in a more recent article published in JAMA Network Open. So cancer is not a risk. Oncologists do have other concerns about patients using cannabis. Pulmonary aspergillosis is a very severe fungal lung infection that used to be felt to be associated with cannabis. In fact, the first case report in the medical literature came from Tony Fauci when he was a fellow at the National Institutes of Health, reporting pulmonary aspergillosis in a patient who inhaled cannabis. I think the best study on this was a look at 19 patients with HIV who had aspergillus in their bronchoalveolar lavage. And it was associated with lower white counts, more severe immunocompromised, steroid use, and prior pneumocystis pneumonia. Cannabis use was not associated with the presence of aspergillosis. I already mentioned my concern about drug botanical interactions, particularly because CBD and THC may impact by way of inhibition of multiple enzymes in the liver that break down pharmaceuticals. There have recently been two Israeli studies which suggested that patients on the new immunotherapies, the immune checkpoint inhibitors, may have worse outcomes if they use cannabis in conjunction with their immune checkpoint inhibitor. This more recent study showed that the time to tumor progression and the time to survival were significantly lower in patients who used cannabis in association with immunotherapy compared to those who did not. The difference seemed to be so remarkable to me that I found it unbelievable. And then when you look more carefully at the article, there is a significant difference in what line of treatment patients used cannabis, used immunotherapy. So this was not a randomized placebo-controlled trial, looked at 68 patients getting immunotherapy, not using cannabis, and 34 that were using cannabis in addition to their immunotherapy. Those patients were more likely to have received the immunotherapy as a second or third line, whereas those patients not receiving cannabis were receiving immunotherapy as first line. And I believe that probably contributes to this difference. Finally, a WebMD survey done a number of years ago of 1,500 physicians in the US, 2/3 said it helps with certain conditions, 2/3 said that it should be available to patients, and oncologists showed the highest level of support among specialists, 82% saying cannabis should be available. Ilana Braun at Harvard did a survey of 1,400 random oncologists. 80% said that they conducted discussions about medical cannabis with their patients. 78% said that these discussions were patient initiated. Again, 2/3 viewed cannabis as a helpful adjunct to standard cancer pain management, and 2/3 thought it was equally or more effective than standard therapy for anorexia and cachexia. However, only less than 50% of those surveyed recommended it clinically, and only a third felt sufficiently informed to make recommendations. So obviously, more education is necessary. And just to show you that even pediatric oncology providers are in favor of supporting of use of cannabis as medicine, 92% said that they're willing to help pediatric patients access cannabis. Again, only 30% were asked to do so in the month prior to the survey. So I think I've lost some of my summary and conclusions, but I will say that despite the dearth of evidence in the published literature on the effects of the flower itself, cannabis or marijuana may be a very useful adjunct to cancer care. There is very little evidence at this point in time that cannabis itself is an anti-cancer agent. Inhalation of flower or ingestion of tinctures or oils may be the optimal delivery system. Again, start low and go slow. The side effects of cannabis use are generally well tolerated. The safety profile is favorable. Caution should be used in elderly with cardiovascular disease. There is no strong evidence of an increased risk of cancer or aspergillosis secondary to cannabis use. Potential botanical drug interactions may be increased using potent oral concentrates, oils of high CBD or THC, and observational study results caution the use of cannabis with immunotherapy. Oh, so there's the rest of my conclusions. All right. So I think that is the end, and thank you for your attention.
If anyone, we have just a few moments for questions. If anyone has any questions they'd like to type in on your screen, but we can certainly start with this. If we can, Doctor, if you don't mind returning to the idea of the whole plant extract versus like a single or a combination of medical cannabinoids, is the whole plant better in general, or does it depend on the symptoms you're trying to affect, like pain versus nausea?
Yeah, well, I think, again, we haven't really had the opportunity to study the whole plant because of the Schedule I status of cannabis as medicine in the United States, although the majority of states now have lightened up and are allowing cannabis for medical use as well as for adult use. So the answer to that question is really unknown, but I think those of us that have worked with the plant believe that the entourage effect that you get when you use the whole plant is superior to what you get when you use isolated cannabinoids, certainly from isolated THC alone. The first study I ever did was in patients with HIV. One group, and as inpatients, got 21 days of dronabinol. One group smoked cannabis for 21 days, and one group got dronabinol placebo. And I'll tell you that the dronabinol patients spent a lot of time in bed, whereas the cannabis patients were up cleaning their rooms and dancing to music and having a better time. So I think that's some of the difference.
Without, as you mentioned, a lot of controlled studies being done, is there a good source of information on the current understanding of, even if it's just from users, of combinations of cannabinoids that might have more positive synergies, or certain strains, or a lot of questions about what strains to take, or maybe which cannabinoids to combine?
Yeah, I mean, combining cannabinoids is something I've really never thought of or don't know how patients do. You know, this is why I'm happy to have med1rx.com to work with, because, you know, they are pharmacists. Generally, I tell my patients, go to the dispensary and tell the bud tender what it is you want to treat and ask them what they would recommend, because they're on the front line seeing the patients, delivering the products, and get feedback on what works and what doesn't work. People say, well, gee, that's a little silly because those people aren't really trained. So that's why it's nice, you know, to have some pharmacists who are interested in this, who can help patients out, make decisions about what might be best to use.
Great. And I think one last question: if you are aware at all of a benefit to changing up what cannabinoids you take, like if your brain or body adjusts to it, is there a benefit, or do you know of one, of every several months or a certain time frame changing what you do?
Yeah, I mean, you know, as I mentioned, I use some products for sleep at night. I think in general, when I advise patients about use of supplements, I say it's probably not best to use the same supplement every day. I stop all of my botanical and vitamin supplements the last 4 days of every month, just to give my body a chance to clean out. And on the first of the month, when I start them again, they say, yay. So yeah, so I wouldn't use the same cannabis strain or the same combination of cannabinoids on a daily basis. I would mix and match. I think the body likes that better.
Excellent. Well, I think that's all the time we have, but thank you so much, Dr. Abrams. That was so interesting, and I learned a lot. I'm sure everyone did. I think now we have a break for people, and we will be showing a Stanford Cancer Institute video that people are welcome to look at. And there's also a survey in the survey section tied to that video. But thank you again, Doctor, so much for being with us and sharing your knowledge. And we'll see you all back for the next session at 1:35.